I welcome everyone joining us for this first webinar in our new series, Connection and Care in an Era of Social Distancing. The world has been turned upside down since the beginning of the year, and in Trinidad and Tobago, life has changed almost daily over the past month. We now found ourselves faced with adjusting to a call for physical isolation and an environment of uncertainty. Our doors at Medcorp healthcare centers are open, and we're deeply committed to keeping our facilities safe for when you need to visit them. We also need to do more for our community at this unprecedented time when we've been called upon to be physically distant. So we developed this webinar series where we hope people can connect in a positive and meaningful way to discuss how they can be proactive about their physical and mental well-being. Before I introduce our first guest, I'd like to point you to the Q&A or question and answer button on your screens. This will allow you to type questions to our speaker. On my laptop, my button appears at the bottom of my screen. But if you're using another type of device, such as a tablet or a phone, your Q&A button may appear elsewhere. We'll try to answer as many questions as possible at the end of the session, but you are invited to type in your questions at any time before then. Our special guest today is Dr. Asta Moore. Dr. Moore is an emergency medicine physician. Born and raised in Trinidad and Tobago, Dr. Moore pursued her undergraduate and medical studies at St. Louis University in Missouri, USA. She graduated from St. Louis University's Emergency Medicine Residency Program in 2016. For the past 4 years, Dr. Moore is emergency medicine in New York City. She is now on the front lines of the coronavirus battle there, where more than half of the USA's cases have been confirmed. Dr. Moore, welcome, and thank you for being with us today.
Thank you, Alyssa. Are you hearing me fine?
Yes.
Okay, so I will go and get started.
Sure. I mean, as COVID spreads from east to west, countries are trying to learn from each other that have had outbreaks of the virus earlier. So we want to hear what your experience has been in New York.
Sure. Well, thank you, Alyssa, again for having me here. So as Alyssa mentioned, my name is Asta Moore, and I'm currently an emergency medicine physician in New York City. As you probably know, the situation in New York City from the news is very dire. Currently, as of yesterday, we've had 53,000 cases of the coronavirus and 1,500 deaths just in New York City. I currently work at one of the hospitals in Manhattan where we've been receiving a large number of patients similar to other hospitals in the city. It's the situation throughout the hospitals, unfortunately, where they're bursting at the seams with sick patients. Every week at my hospital, there's a new area of the hospital being converted into an ICU. The ventilators are being maxed out. We unfortunately have limited PPE, the personal protective equipment. We've had to reuse them. They're not ideal to reuse, but in these times, even we've had to come home and sterilize them ourselves. So it's not an ideal situation, but we're working the best way we can. I've even heard some hospitals, running out of the PPE. So that's, a situation where I'm not at right now in my hospital, but, those providers are facing such situations. With the coronavirus, a lot of things are in flux in terms of the management, the recommendations. And so a lot of trial and error every day and keeping up with, how we should diagnose and treat patients. So it's a moving target always, but we're doing our best one day at a time. Unfortunately, in this process, a lot of the doctors and nurses have also gone sick, and a few of which have died also in New York City. So, it makes you appreciate life and, to take one day at a time again. As a result, the hospital has had to make some changes with the new process. with the new surge of patients of COVID, we've had to cancel all elective surgeries. We've had to resort to other healthcare providers from other areas that are not as busy to assist with the COVID care management, both in the ER and as inpatient. Our ER now is divided into two. So we have a COVID ER and a non-COVID ER to separate the patients as much as possible. But right now, it's probably safe to say that you assume all patients are COVID positive when treating them in the hospital, and appropriate gear and wear the appropriate gear. Our gear so far in terms of the PPE has been what we have, like a bouffant cap and the goggles, and then we wear an N95, and on top of the N95 a surgical mask, and then a visor over it, and then we have a gown and then double glove. So that's our PPE. Some other hospitals have a little bit more intricate or more covered, but that's what we're working with so far where I'm at. So what we're seeing actually in our hospital, how these patients present, basically, they come in with typically fever and a cough and other cold-like symptoms. They less commonly have GI complaints or like a lack of smell and taste, but that is also possible. And so they develop this fever and cough typically 4 to 14 days after exposure. So it has a decent incubation time of a median time of 5 days. And then 1 week after the fever and cough, then they tend to develop the shortness of breath or the dyspnea. So 1 week after the initial symptoms, you can develop the shortness of breath. So if they present with these symptoms of the fever and cough, and the other complaints, two things can happen basically. What we do is we can either admit them to the hospital or discharge them. And that depends on a few things. Basically, if they look well, normal vital signs, then we tend to let them go home. I normally actually have patients who look well walk up and down the ER a little bit and then measure their pulse ox, their oxygen level. If their saturations are above 95, I let them go home. We give them strict return precautions. If they have worsening shortness of breath, that they should return to the ER, and then discharge them on azithromycin, a Z-Pak, for 5 days, quarantine instructions, and then supportive care. So we have a document from the ER, kind of a pre-populated document that we give. We've had a lot of patients come back to the ER even after initial discharge, so quite a number of patients come back to the ER, and then we admit them. But unfortunately, we can't admit just for observation given the limited number of beds. So if they look well initially, we send them home. If they do require admission, and that would mean if they look unwell, they're older, they have a lot of medical issues, they're hypoxic, meaning their blood oxygen levels are low, their increased work of breathing, the difficult time breathing, then we normally get a workup on these patients, which include labs, a chest x-ray as the very minimal. And the labs, we normally order the CBC, chemistry, and kind of another panel of different things, like what they're recommending right now, a D-dimer, ferritin, CRP, LDH, G6PD. And that kind of risk stratifies these patients, and then we bring them to the hospital. The chest x-ray, typically, which we order to if they're being admitted, can show what we call bilateral infiltrates, patchy, so they're diffuse patchy infiltrates. What I'm seeing in the hospital in terms of medical treatment is that inpatient, they're starting these patients on 4 different medications, and that is a combination of the azithromycin, so 500 milligrams on day 1, and then 250 milligrams every other day for 4 days. The hydroxychloroquine, 400 milligrams IV for the first day, 2 times a day, and then 200 milligrams twice a day for the next 4 days. Thiamine, 200 milligrams twice a day for 6 days, and then ascorbic acid or vitamin C, 1,500 milligrams every 6 hours. So the 4 medications that they're using inpatient is the azithromycin, the hydroxychloroquine, the thiamine, and the ascorbic acid. And then obviously if they require the supplemental oxygen, then the nasal cannula or the non-rebreather, or a combination of both, which I've actually seen them doing to kind of max out the oxygen supplementation, and then also to try to prevent them taking up a vent by intubating them. So I've actually seen them maxing out on both the non-rebreather at 15 liters and 10 liters of nasal cannula. Patients are just wearing both on the floors. But however, if they're still not improving on the non-rebreather and the nasal cannula, then the next step would be to intubate them and put them on the ventilator. They're not requiring the BiPAP, which is like a kind of the CPAP mask that you use for sleep apnea, or the high flow nasal cannula, because they are afraid that this will aerosolize particles. So straight to intubation if they're not improving on the non-rebreather and the nasal cannula. And don't use the BiPAP. I don't work in the ICU, so in terms of those specifics, you know, I don't have like a very intricate knowledge on that, but it seems like they've been on the vent for long periods of time, greater than 10 days, and then in a prone position, meaning on their stomach. They tend to do conservative fluid management, so it seems like if you give fluid, you try to be on the conservative side. That has been helping. And then they're not recommending any steroids. So, you know, that's basically how it has been in the hospital. You know, obviously the prevention is key in all of this. So, you know, hoping that no area of the world comes to the situation where, you know, vents are being maxed out and the hospital is being overwhelmed. So prevention is key, and you know, what they've been recommending to the population, you know, should be re-emphasized in terms of isolation. It seems like now they're seeing that even the spread can be through asymptomatic patients. So you don't even have symptoms, but you can still spread it, which is concerning. So, you know, hand washing, staying at home, keeping a safe distance, at least 6 feet between you and the other person, covering your face, covering your mouth when you cough, don't touching the face. And even now they're recommending that if you leave the home to cover your mouth with some sort of mask or some sort of covering, just because they're thinking that the particles can stay in the air for longer periods of time. So that's about it, really. You know, again, I think prevention is the key here. We're taking one day at a time, but definitely it seems like it's hard to say when this will eventually peter out, but at least for the next 6 months, we're dealing with it here.
Okay, great. Thank you. We actually have some questions already. One of the questions was, how do you sterilize your PPE or your personal protective equipment at home? What have they been asking you to clean at home, to sterilize at home, and how do you go about doing that?
There is, so actually this only, as I said, things are kind of, you know, everyday new recommendations coming in. So this only happened 2 days ago where we were told to sterilize them at home. Otherwise, we were just keeping them in kind of like sandwich type bags that the sterile bags at the hospital. So let me just, so basically how it has been is that you hang it to dry in the oven. 1 second, I'll just tell you. At 70 degrees Celsius or 158 degrees Fahrenheit for 30 minutes in the oven. But you kind of have to hook the N95 on with a sort of like a pin, like a wood clip basically, so not to have the mask directly touch the metal part of the oven. So at 158 degrees Fahrenheit for 30 minutes or 70 degrees without touching the metal in the oven. So that's one way.
And
I haven't done it.
Yes.
That's the N95 mask, yes. Yeah.
And we have quite a few questions about the medication that you've talked about in terms of the chloroquine and azithromycin. Can you give us a bit more information about how long ago that protocol was put into place in terms of discharging patients on that? What sort of responses are you seeing with them? And are all US or New York-based hospitals rolling out the protocol right now, or is it a specific hospital?
If I'm sorry, Alyssa, I didn't get, if are all New York hospitals one?
Do they all have the same medication protocol? Or
I see that. Right. Sure. That's a good question. And actually, no. So it seems like there's no standard medication protocol. I've seen other hospitals doing variations of it. But the two medications that they've recommended, I've seen most hospitals, well, I've only seen another hospital, I apologize, another hospital doing the azithromycin and the hydroxychloroquine. The ascorbic acid or vitamin C has a good safety profile, and it's been shown to help the epithelium of the lung lining. So that's why that is recommended. And then the thiamine also has been helping also. I've seen other hospitals do folic acid or just the regular chloroquine. But for this is only inpatient. For discharge patients, some people are not sending them out on anything, and some people are sending them out on azithromycin. The data on antivirals has been very limited. They're doing experimental research and things like that to get a little bit more concrete data. So it's limited data based on these antivirals. But so far, the hydroxychloroquine, azithromycin, thiamine, and the ascorbic acid has been the standard at the hospital I'm working at.
Right. And have you, I mean, when you're in the emergency room, you do tend to see patients sort of at that acute stage. Do you have an idea of what kind of response patients are having when they do take the hydrochloroquine or the azithromycin or the absorbing acid?
You know, basically I only see them in the ER on the initial type of presentation. I maybe interact with them maybe for about 2 to 3 hours, and then they get admitted to the floor or to the ICU. So I don't see the effects of those medications long term, but we do start it in the ER. Our main goal in the ER is to make sure that these patients can deteriorate very quickly in terms of their breathing. So our main goal in the ER is to make sure that their oxygen levels are supplemented so that they're above hopefully 88, 90 on their pulse ox. And then if we need to intubate them, we do that in the ER also.
Right. And what sort of dialogue are you having with your critical care department?
In terms of the,
I guess just in terms of the global team effort, where I would imagine that your ICU is quite full at this time. So you're sending patients.
Right, sure. So they're trying to stave off intubation, meaning attaching them to the ventilator as much as possible. So really, they're trying to stave off the intubation. So if really they're not doing well on the non-rebreather and the nasal cannula, then they would intubate them. So they're trying to max out other things before intubating them. But if they need to, then unfortunately, then like ethical decisions are being made in terms of taking off older patients who may have not good prognosis and then put a younger patient on the vent. So that has not happened too much where I am right now, but I've heard that happening because the ventilators are being maxed out, then older patients who don't have a good prognosis are being extubated so that the younger patient can be vented, yeah.
So your hospital protocol on these ethical decisions that might be faced by ER or critical care physicians, has that been documented as yet as to what you should follow if you were deciding?
Sure. No, unfortunately, it's been left to our discretion. And it seems like that is the case with other hospitals also, in terms of if they have the vents, they will obviously put the patients on the vent. But if the goals of care are such that the family and the patient wish that they don't want to pursue being intubated or being on the vent, then we recommend that given the prognosis, because high mortality once they're on the vent. So it's likely that the younger patient would survive if they're put on a vent compared to the older one. So yes, we do have those discussions with the family, and it's the threshold to make them what we call DNR, DNI, meaning do not resuscitate, do not intubate, is a little bit lower in this time. So yes, so no, it's left to our discretion basically.
And are the parameters for intubating the patient also left to the physician on duty's discretion, or has the hospital?
Correct. Yes, I mean, you kind of have a general idea that the patient needs to be intubated because their oxygen levels are not great, or they're having a difficult time breathing, or when they do like a blood gas, it's like a lab test through the that they pull from the blood, and they see what the levels of like the CO2, the O2 levels are, like the ventilation perfusion in the blood. Then if that's not good, you get it's not very subjective, it could be objective also when you need to intubate, and so you have an idea of, yes, that the patient needs vent support.
Right. Okay, and when we do have a question, which I'll read to you. We understand that the Chinese recommended a model in which positive or symptomatic persons are sequestered from the populace as a means of preventing further dissemination of infection. Your hospital's model seems to discharge persons back into the populace. Is there any reasoning behind your model? So you had mentioned to us, Dr. Moore, that you're trying not to intubate patients, or you don't have enough beds, so you're trying to send people home.
Correct.
And this sort of seems counterintuitive to what else we know about quarantining persons or keeping them away from the rest of the well population. Do you know?
Sure. Sure. Yes, unfortunately, we work within the restraints of the infrastructure of the hospital, so we can't quarantine everyone in the hospital. So if we do send the patient back home, the teaching is that they have to be in their room, basically, and then 6 feet away from all other persons. They wear a mask, the other people in the home wear a mask. So it's not a perfect situation, unfortunately, and sending them back also, it is true, exposes non-infected people to the infection, but it's just, we just don't have space basically in the hospital. So yeah, so as much as possible, we tell them the instructions that they need to be isolated in their own home.
Right. So I welcome any other questions about that point, or any others. In the meantime, we have a question. What is the basis of using a surgical mask over the N95, as the virus can pass through the surgical mask and may give a false sense of security?
The surgical mask over the N95 is just so that the N95 really just like you won't touch the N95 directly with your own hands. It's just kind of a cover over the N95. So no, it doesn't, that's true. It doesn't really protect per se. The N95 is the main barrier. It's just if you by chance touch the N95, you won't touch it directly. You just touch the surgical mask over it.
And is that because you're trying to preserve the N95 in terms of the shortage of PPE? Would that be the same protocol if there was an abundance of N95 masks?
Probably not. So yes, it's done as a way to preserve the N95 as a second barrier. And as I said, like, just so that, the integrity of the N95, there's something over it. Yeah.
Right. And I mean, given the shortage of PPE worldwide and these new I don't know if to call them recommendations yet, and let's say the US, and they've already been in Asia, to wear a mask in the for the general population when they, walk around, or maybe they're at home with someone who is isolated. What type of mask is suggested for the general population? Would a cotton homemade mask or fabric mask be suitable? What we're calling dust masks.
Right. Yes, it's hard because you'd want people to wear the right thing, but we don't have the right thing for everyone, which is the N95. So yes, any type of material that covers your nose and mouth would be at least 75% fine. Obviously, if you're symptomatic, then you should stay at home and not walk around with symptoms. But if you're asymptomatic, yes, and anything that covers your face would be fine, and the nose and the mouth per se. A surgical mask, I don't know the logistics of buying things like that, out in the open, but surgical mask is the kind of like the lighter one where that is fine, appropriate to use.
Great, thank you for that. So I'm just going to give everyone a bit more time to see if there's any other questions that they have before we wrap up.
Okay.
But maybe you can tell us in the meantime, Dr. Mo, how have you been coping with working in this circumstance? Before we started this, you were telling me that the patients that you're seeing are really just this sicker, and you are facing these decisions about whether someone that you might ordinarily intubate might not be intubated this time. How do you deal with that?
Sure. I personally, it is difficult, but we have to realize the kind of on a broader scale, things that we want to preserve for potentially another patient. So yes, it is difficult decisions. Actually, I personally have not intubated anyone as yet, which somehow I've got a white cloud so far, touch wood. But that type of decision, is difficult. It is difficult, and it basically case by case. But yes, I've seen my colleagues, some of them signing these DNR, DNI papers earlier rather than later. And there's no more like a let's wait and watch. It's kind of, you don't have a good prognosis. I don't think the intubation would work. We would like to make you DNR, DNI. And the family and the patient, at that time, the patient is very sick. So sometimes they're not able to make a decision, and the family understand the seriousness of the situation and tend to agree to make the patient DNR, DNI because of the poor prognosis.
Right. Yeah. It's very a unique time to be a medic, and a lot of difficult decisions for you to make. We have another question from a participant. Was there discussion at your hospital about sterilizing a mask in a dryer versus the oven? The dryer is at 135 degrees Fahrenheit. Will a longer duration in the dryer kill the virus?
That is a good question. I'm just looking at something here. I would assume that would make sense and would work, yes. I just don't know if the dryer is like affecting the integrity again, if it's moving about too much in the dryer, but I would assume that might work, yes. Or you don't even have to put it in a dryer or an oven. What I'm also reading here is that if you just leave it out in a dry atmosphere for 3 to 4 days, that will also dry it out. So if you just leave it out for 3 to 4 days and just let it dry out, that will also be fine.
Right.
You don't need to put it in an oven or a dryer, but yes, just keep it in a dry place for 3 to 4 days. And the virus will not have survived by that time.
Right. And we have another question about whether you've noticed a reduction in patients presenting at the emergency room when the Navy hospital boat arrived in New York City. And
Right. That, to my knowledge, is it's like an outpatient center clinic. So they want to get these maybe like cancer patients away from the inner city. And so, no, I think not really. I think they only have like 20 patients there so far, what I've read from the articles online. So nothing too significant. Like, so 20 patients are on the Navy boat, as far as I know, and maybe it has changed. But it has not affected so far the number of patients coming into the ER, yeah.
right. Okay, great. Well, we don't seem to have any more questions coming in. Dr. Moore, it's an honorable time to be doing what you're doing. Thank you so much for taking the time out of your busy schedule.
Of course. Thank you, Alyssa, again.
We hope you remain healthy while you're doing the work that you're undertaking.
Okay.
I also want to thank the members of our Trinidad and Tobago healthcare community for tuning in today as part of their commitment to remaining proactive and informed about this pandemic. And to the rest of our participants, thank you for helping us foster a positive sense of community today. We enjoyed having you all and hope that you'll continue to join us for next week's webinars, the details of which will appear on St. Clair Medical Center's Facebook page and through other electronic communication. If you signed up for today's live webinar, you will also receive an email with the links to next week's webinars. So let's all remember to wash our hands often, not touch our faces, stay at home, and maybe let's just all do at least one kind thing for someone else today. So thank you, Dr. Moore, and have a great day.
Thank you, Alyssa, and thank you everyone again for your participation and attention. Thank you.
Bye.
Okay.